Hello everyone and welcome again. So continuing our discussion about the orthopedics trauma basic principles class, and after we talked about the fracture treatment, here we will talk about the fracture complications. This video will be about the early complications, which are the visceral, the vascular and the nerve injuries, and then we will talk about the infection and the hemoarthrosis. So let's start. Let's start with the visceral injuries. The visceral injuries commonly associated with the fractures around the trunk, especially the ribs, the pelvis, and the clavicle. So visceral injuries would be examples for that would be the lung, the vessels maybe, the bladder. So examples, the rib injuries penetrate the lung and lead to pneumothorax. And the pelvic fractures penetrate the bladder or urethra. So those injuries has to be expected and looked for when there is fractures around the trunk. Now for the vascular injuries. So arterial injury need emergency treatment. The artery may be cut, punctured, compressed, kinked, spasm, and intimal dissection. The causes include initial injury, swelling of the soft tissue compressing the vessel, especially during compartment syndrome, the bone fragments cutting or puncturing the vessel, and reduction maneuvers and surgery also may lead to injuring the vessel during the procedure done. So the vessel sometimes look normal under direct vision, but is blocked by thrombus or spastic. The net effect of the arterial injury vary from a slight decrease in the blood supply to tissue distal to the fracture to profound ischemia and tissue death. So it could be slight decrease and it could be profound ischemia. The clinical features of the vascular injury include that the injured limb is cold and pale, the distal pulses are weak compared to the other side or absent, so you need to examine both sides for comparison, and the capillary refill is delayed. The patient complains of numbness in the affected limb. So if the injury is in the ribs, then think of the subclavian artery injury, and if the injury is in the shoulder, then think of the axillary artery injury. So basically you think of the when there is an injury, you think of the artery that is close to the injury. In case of the elbow, you think of the brachial artery. In case of the pelvis, you think of the internal iliac artery and its branches. In the femur, you think of the femoral artery, and in the knee, you think of the popliteal artery. The treatment would be with resuscitation of the patient according to the advanced trauma life support trauma protocol explained in one of the videos in this class titled Emergency Management of the Trauma Patient. So basically go back to the playlist of this class and you will find this video. If the limb is acutely ischemic and the injury is obvious, knee dislocation or femoral fracture, then vascular injury at the same level and immediate surgical exploration and repair has to be done. So basically if the distal pulses are absent and the limb is pale, then and the injury is obvious, for example, dislocation of the knee or femoral fracture, then the vascular injury at the same level and immediate surgical exploration has to be done. If not acutely ischemic and you suspect vascular injury, then all the bandages and splints should be removed and duplex ultrasound is used. And if the Doppler shows injured artery, then should be referred to immediate surgery and repair. And if the Doppler is negative and the fracture is not reduced and the position of the bone suggests compression on certain arterial anatomical position, then reduction is necessary and the circulation is reassessed again repeatedly over the next 30 minutes. If there is no improvement, the vessel must be explored by operation with the help of the angiography, and torn vessels can be sutured. A torn vessel segment can be replaced by a vein graft, and arterectomy if the vessel is thrombosed. And if operation has to be done for the artery to be repaired, then operative holding method of the fracture is a must because you already opened the fracture, and it could be internal or external fixation depending on the situation. Now for the nerve injury. So the nerve injury means abnormal nerve function after injury. The Sidon classification classifies nerve injuries into 3 types: the neuropraxia, the axonotemesis, and the neurotemesis. And we will explain them in the next slides. So let's start with the neuropraxia. So in the neuropraxia, the function of the nerve axon is disturbed by ischemia occur following to direct trauma to the nerve, traction or pressure on the nerve. So it could be direct trauma, it could be traction, and it could be pressure. The ion pump stops working, so no impulses are transmitted, and the degree of impairment of the nerve depends on how many axons are affected. So the structure of the nerve in neuropraxia is unaffected, and once the insult has been removed, the ion pump works again and the function is restored. Example for the neuropraxia is when you sleep on your hand or arm and you wake up feeling tingling sensations that goes away quickly after you wake up. So after a little bit of removing the pressure on your hand, you find out that the tingling sensation has gone away. That's what we mean by neuropraxia. The second injury is the axonotemesis. So it is more severe type of injury. There is section of the nerve, axon is dead. The nerve function can't return initially even if the insult has been removed. So the myelin sheath stay intact and the axon able to grow again, because remember, the nerve has the ability to regenerate. So nerve axon grows at a rate of 1 millimeter per day, so you can estimate the duration depending on the distance traumatized. Tinel's sign is a sensation of tingling on percussion over the regenerating segment, so it is good for assessment of the healing. Scarring within the myelin sheath prevents regeneration and it would lead to incomplete recovery. The third level of injury to the nerve is in neurotemesis. It is complete cut of the nerve due to penetrating injury, and the severed nerve has to be explored surgically and repaired after. And if not, then it might fail to reach the correct target, or may be blocked by scar tissue or form painful neuroma at the site of injury. So there is a high risk of the nerve failing to heal. So it has to be explored. And this picture explains the Sidon classification. So in the neuropraxia, there is only pressure on the nerve. There is no injury whatsoever. In the axonotemesis, there is a pressure that leads to an injury in the nerve, but the nerve is able to regenerate, so it would heal like that. In the neurotemesis, there is a complete transection of the nerve, so basically it's a complete cut of the nerve, and it has to be explored and treated surgically. The clinical features of the nerve injury. So nerve injury is common in fractures of the humerus and around the elbow and knee joints. Neurological examination elicit motor dysfunction or sensory dysfunction related to the nerve injured. Treatment of nerve injury is that you identify the injury and the cause, and you limit the progression by reducing the fracture. And if the likelihood of neurotemesis is high, then schedule the patient to surgery. Axonotemesis injuries are observed for improvement on a period of 3 to 6 months, and if no improvement, then surgery is required because the injury is most likely going to be neurotemesis. Now let's talk about another topic of the complications, and that is the infection after fractures. So infection could be osteomyelitis, cellulitis, or muscle infection. The osteomyelitis in orthopedic trauma is a very significant problem because it is hard to treat and affect fracture healing. Open fractures may easily lead to osteomyelitis. That is why antibiotic cover is so important in these fractures. Closed fractures rarely get infected unless there is severe soft tissue injury or the fracture treated with operative, reduction, and holding methods. Antibiotic treatment, wound care, multiple surgical procedures are needed for the osteomyelitis to be treated, and the patient factors like diabetes, immunosuppression, obesity, and smoking are risk factors to infection. Infection may lead to delayed healing, non-union, loss of function, and amputation, so it's very significant. In the clinical features, the patient presents with localized pain that is chronic, worsening, and it is not related to activity, and it is worse at night, and it is associated with fatigue and rigors. And on examination, there is tenderness, induration, and maybe there is discharging sinus. You send the patient for blood tests like CBC, ESR, CBR, and blood cultures, and you take swabs from the wound, and that's sent for culture and biochem. And you take x-rays, they show bone resorption and periosteal reaction to osteomyelitis, and CT and MRI might be needed. The treatment of the infection is that knowing the infective microorganism through the culture, then starting the antibiotic therapy according to the microorganism detected, and debridement procedures are needed in osteomyelitis. Finally, let's talk about the hemoarthrosis. So, the fracture inside the joint capsule may cause bleeding into the joint. So, the fractures that occur inside the joint cause bleeding into the joint, and that is the joint is swollen, painful, and the patient refuses to move it, and it is treated with aspiration. And with that, we reach the end of this video. Thank you guys for watching. Please make sure to like and subscribe. And if you want to support more, you can by subscribing to the Patreon, link provided in the description of this page. Thank you for watching, and peace.